15 minutes. So after 15 minutes, we can stain, and maybe if it's such an emergency, we can give the report that day itself. Then it's cost effective, so not that much cost for all the syringe needle, the fixative, the Copeland staff. So it's cost effective and widely available, and it can be used in the outpatient settings without hospitalization. The disadvantages is like, as I have already mentioned, cannot assess tissue like which are deep, which are not visible. And some cases may require repeat sampling or further testing. And it's not always the final diagnostic method because in some situations, especially in case of where we need the architectural features also to make a diagnosis of malignancy, like the capsular invasion or a vascular invasion in endocrine tumors, FNAC may not be that helpful in differentiating benign and malignant lesions. So today's session for the general practitioners. So why is cytology important for the general practitioners? You know, GPs are the first point of contact for patients with lumps, nodules, or like all abnormal results. So they should know, actually, this deciphering cytology reports is for them. And understanding cytology reports help in early detection of malignancies and other conditions, and also for guiding the patients, the further step regarding the further steps of management. At the primary level itself, the cytology reports enable the GPs to distinguish between benign and malignant cases, so that the patient, when they are approaching the first clinician, you yourself can reduce the unnecessary anxiety or delays in treatment. And it plays a critical role in deciding the next steps, whether to reassure, monitor, repeat the test, or refer to a specialist. And it also helps in explaining results to patients. If you can decipher the report properly, you can explain it to patients, because we, the pathologists, are not supposed to explain the cytology reports to the patients. We just give the report to them. They'll ask. Sometimes we won't say much. We are not supposed to do that. Only the clinician is supposed to explain the results to patients. But if it's a benign lesion and the patient is too anxious to know, we'll always say, oh, there is nothing to worry about. പേടിക്കാനില്ല, കുഴപ്പമൊന്നുമില്ല, ഡോക്ടറെ കൊണ്ടുപോയി കാണിച്ചാൽ മതി. That's our that's how we reassure the patient. Then a well-interpreted cytology report can prevent over-investigation. ഈ പറയുന്ന പോലെ ഇപ്പോഴത്തെ ആൾക്കാർക്ക് എല്ലാവർക്കും they are always worried about, after too much of awareness about cancers and lumps and all. So they'll be coming even with a small nodule over the skin. And if you get a neural tissue or a schwannoma or a neurofibroma, so that point itself, the patient is getting relieved. And you need not go for expensive investigation. So that is the importance of cytology and the understanding of the cytology report. So, 1 second. I'm not able to read because of the this thing. How I can read, I don't know. Anyway, so about the reporting format, you know, previously, that's what I said in the beginning. Previously, we used to give descriptive reports. Or when it is an overt malignancy, we used to give as malignant cells positive. But for others, there was no uniformity in the report. There was always a subjective error. There was always an inter-observer variability, because each cytologist, each cytopathologist may be using their own language to express what they saw under the microscope. So now, there is a radical change in the reporting format. It has become uniform throughout the globe, and that has become very, very effective in planning further management as well as understanding the cytology reports. So the descriptive format of cytological reporting has evolved or has transformed to a more standardized reporting systems. Like the most common word you know about reporting system is the Bethesda system. And there are others also depending upon the site. So, as I just mentioned, it's just a repetition of what I told you. The traditional cytopathology, which we used to do at least 2-3 years before, until 2-3 years before. So the reports were just descriptive and subjective, and they were often narrated. As I just mentioned, it was based heavily on the individual pathologist's descriptions. And so the reporting format did not have a standard terminology. So the different labs, different states, different countries use different terminologies. Then there was no stratification, or there was no presumption of the risk underlying a cytology report. But nowadays, these reports give how much this report is going to be malignant. What is the percentage of chance of malignancy in a particular report? Then there was always an ambiguity in diagnosis, because when the pathologist is not sure whether the cells are malignant, so we just term them as atypical cells. And the clinician is also, if they don't have a clinical diagnosis as to whether benign or malignant, so that result became an ambiguous report. But now, with the with the introduction of the systematic reporting systems like Bethesda and others, there is introduction of standardized terminologies throughout the globe. Across the world, we use standardized the uniform reporting formats and uniform terminology. And all these systems also incorporate a risk-based classification. So what is the ROM? The risk of malignancy in a particular report, that is also given very clearly. And that classification, or that quantification, is based on previous statistical analysis. Then the most important thing is the reproducibility of these reports. There is a marked reduction in the inter-observer variability, but enhances the reproducibility. And as I said, not just the pathologist, but looking at these systematic reports from the cytology lab, even a clinician is able to understand so what exactly the patient is having. So the communication with the patient also becomes very clear and precise. So I just go through these different systems for your understanding, for your knowledge, just for your information. So there are several systems for each site. Of course, for cervix and thyroid, we use the Bethesda system. For salivary gland, there is a Milan system. For urinary cytology, there is a Paris system. And for pulmonary cytology, the Ale system. So these are the systems now in practice for reporting cytology from these sites. Now coming to actually, I am not able to say the most common, because I don't know whether thyroid or breast, which is common. So because CA breast or breast lesions are also very common, thyroid lesions are also very common, and even a lymph node. So thyroid, breast, lymph node, salivary gland. So ours is a tertiary care center, which has all the specialities. So we get all the lumps. The statistics I'm not telling now, but anyway, this is very common, and anybody can send a thyroid swelling to a pathologist for FNAC. And this is either the pathologist takes the FNAC at the cytology lab, or it can also be submitted by a radiologist or a clinician as submitted cases. Nowadays, because ultrasonography is also a primary mode of management of investigation in thyroid lesions, and if the lesion is small or a single one, always the radiologist can send a FNAC to the pathology lab. So, FNAC is a gold standard for evaluating thyroid nodules, and it always helps, almost always help differentiate benign versus malignant nodules. And now we all use the Bethesda system, which is otherwise called the TBSRTC, standing for the Bethesda system of reporting thyroid cytopathology. So that is the full form of TBSRTC. And hence it is a standardized reporting. And we have 6 categories under this thyroid TBSRTC. Like one is non-diagnostic, second is benign. So category, so that's what we say, Bethesda category 1. So if you see a report as Bethesda category 1 means it is non-diagnostic. Bethesda category 2, it is TS. We always use the TB-SRTC category 2, benign. 3 is ATP of undetermined significance. 4 is follicular neoplasm. 5 is suspicious of suspicious of carcinoma of malignancy, and 6 is malignant. Okay, so these are the 6 categories, and under each, so non-diagnostic means like many times, even when it is a colloid goiter or a colloid nodule with cystic change, we'll aspirate abundant colloid only or degenerated colloid, so cyst fluid only without any cells. Then what acellular, that is what I just mentioned, no cells, no colloid, so that is again a non-diagnostic aspirate. Then sometimes thyroid is a very vascular organ, so many times we'll be aspirating blood. We don't use suction nowadays. We use only the 23 gauge needle to take FNAC from the thyroid. So we'll be poking with the needle and taking with the suction, we release the material onto the slide. Then we may get blood, so obscuring blood, clotting artifact, drying artifact, etc. All these make us near non-diagnostic. We won't give any diagnosis. We just name it as TB-SRTC category 1. And benign, so the most common lesion, the goiter. And goiter, now the current terminology, pathological terminology is follicular nodular disease, TFND, thyroid follicular nodular disease, which can be just a colloid filled nodule or a cellular nodule. But when you see abundant colloid with those benign thyroid follicular cells, we know it is a follicular nodular disease. We give the category, and if we are very sure about the subtype, we'll always give it as a follicular nodular disease. But the first one must be the category, TB-SRTC category 2, benign. Then another benign situation in thyroid FNAC is always a lymphocytic thyroiditis. And in thyroiditis, we always see abundant lymphocytes. And with other changes, we may be able to label it as just a lymphocytic thyroiditis or Hashimoto's thyroiditis. And that too with correlating with the ultrasound findings as well as the thyroid TFT. Then granulomatous thyroiditis, not as common as lymphocytic thyroiditis. Definitely we'll be seeing those granulomas, epithelioid granulomas, along with the other findings. So that these are the categories that come under benign 2, category 2. Then this is the most problematic one, atypia of undetermined significance. Many a times, when the aspirate is not that cellular, but cellular much more than expected, and we see some nuclear features, we see some architectural features like more of follicles, more papillae, then, but we are not sure whether it is a follicular neoplasm or a papillary carcinoma. And we are very sure that it's not just a benign lesion. We group such lesions as TB-SRTC 3, that is atypia of undetermined significance. And under this comes a follicular neoplasm of of undetermined lesion also come, because we see a few microfollicles, but we are not able to say anything more. Then the next one is follicular neoplasm. This is when we always see small follicles. The smear is too cellular and they always take a microfollicular pattern rather than the monolayered sheets which are seen in the benign category. And the cells look almost uniform. Then we can only say that it is a follicular neoplasm, because to diagnose follicular carcinoma, we need to see the biopsy, we need to see the capsule, we need to see whether there is invasion, capsular invasion or vascular invasion. So we can only say that it is a follicular neoplasm. And follicular neoplasm again can be of the Hertel cell type. But now worldwide, the Hertel cell, that terminology has been replaced by a more generic term, that is oncocytic. So we have to specify whether the follicular neoplasm is oncocytic or not. So when you see these reports, like I think it's very clear what to do next. So that is the most important thing. I'll be coming to it. And suspicious for malignancy. So it can be any malignancy. It can be a papillary thyroid, medullary, metastatic, lymphoma, etc. And malignant. So many a times, papillary thyroid carcinoma is also very, very common. So we always get a report from the clinician as well as a radiologist that there is a suspicious lesion, and then we'll also be aware of those ultrasound reports, the radiology. So we'll be looking at the smear very carefully, and we'll be looking for those nuclear features, which you all know about papillary thyroid carcinoma. Then we have the other malignant features also, malignant carcinomas, malignant tumors, the other carcinomas of the thyroid. And we can make a specific diagnosis many a times based on the cytological features alone in the thyroid. So, as I said, this TB-SRTC gives the risk of malignancy also. So, the statistical studies show that even if it's a non-diagnostic, inadequate smear, the risk of malignancy could be 5 to 20 in those reports, from those reports in that particular patient when the thyroid is subjected to biopsy evaluation. So, so then the question is, what is adequacy in a thyroid aspirate? So, in general, all textbooks say that at least 6 clusters with 10 thyroid follicular cells are required to say that a smear from thyroid is adequate. So anything less than that is inadequate, or as I just mentioned, the non-diagnostic category, the risk is 5 to 20. So what will you do when you get such a report? You can always repeat the FNA. So we know when we are very sure that there is a nodule and it is a palpable thyroid, and we didn't get any aspirate. So when the patient comes for the report, we always try to convince them and take another repeat aspirate. But if they are willing, then we'll write to the clinician that FNAC may be repeated under ultrasound guidance. And it has to be repeated because you have not got any report for that particular patient. But when you get a category 2, that is benign, still there is a 2 to 7% risk of malignancy. And so these patients should always be kept under follow-up. Then ATPR of unknown significance, that is category 3, is 13 to 30. What you can do is repeat the FNAC and again keep under close follow-up or surveillance. So that is very important. These patients, it could even be a malignancy. So if the repeat FNAC or the ultrasound, the clinical evaluation, all these are highly in favor of a malignancy, we may have to do a diagnostic lobectomy or subject the patient to molecular testing, because the molecular testing is different for papillary carcinoma. Molecular pathology is different from papillary carcinoma and the other type of carcinomas, especially follicular. So if you have a BRF gene mutation and a RET mutation, that is more in favor of papillary carcinoma. So molecular testing is also done as a surveillance method for this category. Then the last one, the fourth one, category 4 is follicular neoplasm. Of course, it is a neoplasm, and you don't know whether it is an adenoma or a carcinoma. So the risk of malignancy is very high, that is 23 to 34. So a diagnostic lobectomy has to be done, and further investigations as required from the biopsy report. Then suspicious of malignancy, again, you cannot wait. You have to do a lobectomy based on the zoological findings. And if it is a diffuse lesion or you find suspicious lesions in the other lobe also, you need to go for a total thyroidectomy because the risk of malignancy is too high, 67 to 83%. And when we give a malignant report, that is category 6, that means 97 to 100%, it's going to be a malignancy. And so total thyroidectomy is the rule. So this is how you should go about, interpret a thyroid FNAC report and plan your further management. For a few sample reports, so if you get a TB-SRTC category 1, so that means it is non-diagnostic And we may give a detailed descriptive report as well as like specimen processed and examined but unsatisfactory due to insufficient cells, or a repeat aspirate under ultrasound guidance should be considered. Then epinephrine thyroid, if it is category 2, means it is benign. So if, as I said, if we are very sure that it is a follicular nodular disease, we'll always say that. And if there are oncocytic cells and lymphocytes, we'll consider the possibility of a thyroiditis also. Then category 4, follicular neoplasm. So in that case, we have to write another negative finding also, that there are no nuclear features to suggest papillary carcinoma, because that's very important, because there is follicular variant of papillary carcinoma. And, though this Bethesda was introduced in 2007, it has been updated twice after that, in 2017 and now latest in 2023, because in 2017 again, the classification, the WHO classification of thyroid neoplasms was revised, and new entities, especially regarding follicular neoplasms, was introduced, like non-invasive follicular tumor with papillary thyroid carcinoma-like features, papillary carcinoma-like features. So that is very, very confusing, because previously, whenever we saw the cytological features of thyroid, papillary carcinoma thyroid in the nuclear, papillary carcinoma, the two things is, one is architecture of papillae and the other one are the nuclear features. So whenever we used to see those nuclear features, we used to give only the diagnosis of papillary carcinoma. But now there are other entities also, like a follicular adenoma, which is non-invasive, can have a papillary carcinoma-like nuclear features. So such entities are also included. So those entities will come under category 3, the ATPR of undetermined significance. Only with biopsy, we'll be able to confirm the diagnosis. Then malignant, as I just mentioned, the commonest one we always see is a papillary thyroid carcinoma. Of course, we do come across medullary carcinoma also. But then if it is, we are very sure that it is papillary thyroid carcinoma, along with category 6, we give the diagnosis of papillary thyroid carcinoma. So just a few pictures. I'm not going to explain all these, not much time for these. So this is actually a non-diagnostic smear. This is what is called the thyroid follicular nodular disease with, as I just mentioned, the monolayered sheets. They are sheets of benign thyroid follicular cells. But when you see large areas with lymphocytes, or even a small paucicellular aspirate with lymphocytes, we can always consider, along with the TFT and the ultrasonography, the possibility of a lymphocytic thyroiditis. And category 3, the most confusing, as I said, the AUS, the ATPR of unknown significance. So that is always a headache for the pathologist. And when you see the report, so you should judiciously decide what next based on your clinical impression as well as the sonological findings. And this is one straightforward case of papillary thyroid carcinoma, which is not the situation we come across, but sometimes we do get these kind of smears, and we'll be able to make 100% confirmatory diagnosis of papillary thyroid carcinoma from the cytology smear. So that's all about thyroid carcinoma. It's just a bird's eye view on cytology of thyroid due to paucity of time. Now let's go to the next common aspirate we do daily, and which submitted breast FNACs are in fact rare. They are always sent to the pathologist for FNAC. So, breast lesion, because they are not very much visible, they are to be palpated and found out. And so they always need a fine needle aspiration cytology. And with cytology alone, we can differentiate benign, atypical, or borderline and malignant lesions. It's always a very quick procedure, minimally invasive, just a prick, the pain of a prick, and useful for initial evaluation. That's always the first line of investigation in any patient with a breast lump. And now the system of reporting of breast cytology has also been standardized with the IAC Yokohama reporting system. So, what are the indications for FNAC in breast lesions? The common lesions, the common scenarios that are coming to us are the palpable breast lumps, maybe solid or some maybe cystic as seen in the mammogram. Of course, this here again, the triple testing is very, very important. The clinical impression, the mammogram or other radiological investigations, and the cytology. So these triple testing, which will always make an initial diagnosis for any breast lump. The nipple discharge is also like we can take the nipple discharge on a smear, on a slide, smear it and see under the microscope. Evaluation of axillary lymph nodes. So whenever you see axillary nodes in a female, we always think of a metastatic lesion and axillary node aspirate, recurrent or residual lumps post-surgery. And sometimes, no, in large fatty breast, we may not be able to do an aspirate with that 22 gauge needle and suction. So those cases, we have to do a guided FNAC. Advantages I've already mentioned, so I'm not repeating, but the disadvantages I would wish to mention, because many times it's difficult to differentiate between a ductal carcinoma in situ carcinoma and an invasive carcinoma of the breast by looking at the cells alone. That's very difficult. And if at all it's a malignancy, but the lesion is very small and desmoplastic or fibrotic or serous, we may not get any cells from those aspirates. So false negative aspirators can pose a problem. And, the management of any malignancy of the breast, it's always the first step itself. We need to have the hormonal status or the in HER2 ERPR status. So that is not done in cytology reports in our center. And, inadequate sampling. So adequacy in breast aspirate is also very, very important before you commit on diagnosis. So previously, as I said, we used to give descriptive reports as atypical cells or benign ductal epithelial cells, etc., epithelial proliferative lesion. These were the terms we used to give, but now we have to give based on the Yokohama categories, that is the International Academy of Cytology categories. There are only 5 categories: C1, C2, C3, C4, C5. The description given on the screen, you can see insufficient, benign, atypical, suspicious of malignancy, malignant. So that's the category for any cytology. Now we'll see what is the risk of malignancy for each category. So insufficient or inadequate. So what is the adequacy in breast? So in fact, many of the literature, it's not very clear, but some of the textbooks do give that at least a minimum of, at least 7 clusters with 20 ductal epithelial cells. So that must be the adequacy for breast aspirate. So anything less is insufficient or inadequate. But again, the risk of malignancy is 2.6 to 4.8% in such cases. So what we have to do is review the clinical and imaging findings, repeat FNAC, and if required, we may have to go for a core needle biopsy. So that is, that is the first step in evaluating any suspicious breast lump. They do a core biopsy or a true cut biopsy of the breast. Then breast lump. Benign, category 2 is benign. So there is a risk of malignancy, 1.4 to 2.3. So here again, the triple test, as I just mentioned, the clinical findings, clinical examination findings, the mammogram or MR mammogram or whatever radiological findings. And along with that, we have to correlate the cytological findings also. If all are in favor of a benign lesion, nothing further need to be done. But if anything is suspicious or indeterminate, we need to repeat the FNAC, or if they all are suspicious, you have to proceed with the co-needle biopsy. And when we give that atypical, like the thyroid AUS, when we give atypical, that means something is problematic. It could be a malignancy as well. So in those cases, again, review the clinical and imaging findings, repeat the FNAB. If further, again, if you are getting atypical, as the cytology report, consider a co-needle biopsy or the excisional biopsy. So because nowadays wide excision and breast conservation surgery is also being done very frequently. So we can go for an excisional biopsy also. If it's a small lump, you're not very sure that it's going to be malignant, then you can go for excisional biopsy. Then suspicious of malignancy. When we give suspicious of malignancy, say the risk of malignancy is always 84.6 to 97. And in those cases, correlate with the Okay, so the review the clinical and imaging findings. And when with this smear, a core needle biopsy, it's mandatory. Just correlate with the clinical and imaging findings and do a core needle biopsy. And if you get a malignant report as malignant cells plus is category 5, so that means 99 to 100% there is risk of malignancy. So again, review everything, clinical imaging, proceed to core needle biopsy. And if triple test is concordant and malignant, proceed to the definitive management. You need not, anyway, core needle biopsy with immunohistochemistry, you can proceed for the definitive treatment. So these are some example reports I've already mentioned. So I am not going to the details again. So as I said, IAC category, if you get a report as IAC1, so that means it is inadequate or insufficient. If you get IAC2, that means it's benign. So which is the most common benign lesion, especially in young females. So it's a fibroadenoma, and we are able to give a specific report of a fibroadenoma as a benign epithelial proliferative lesion as fibroadenoma. Atypical, that means the pathologist is not very sure whether it is an overt malignancy or it's benign. But it need not be benign, because only when we see some of the atypical findings, we commit on this atypical. So it's going to be a problem. So as I just mentioned, follow up these patients and do go for repeat FNAC. And again, as I said, the triple method is very, very important for breast lumps. And malignant, always, when we are 100% sure, we'll definitely give a diagnosis of carcinoma breast. Just a few pictures. Pap smear, all these are Pap-Nicolau smears. Now, again, something which is going on in our state and even across the world, with an aim to eradicate cervical cancer by 2030. So even our government has asked all of us to do as much as Pap smears as possible. So even in our SAT cytology lab, lots and lots of Pap smear are coming every day, and there are follow-up meetings every week. How many have done? How many have turned to be malignant? How many are atypical? And so on and so forth. So this is again very important. But all the females present here, if I ask the question, I don't want the answer. How many of you, about 30, how many of you about 30, at least about 30, have done a cervical smear once in your life? I am sure the answer will be no. No one. So that's our problem. Though it's easily available, it doesn't cause any pain, no difficulty. People are not willing. But now the common man, they have become very much aware, and they all are doing this Pap-Nicolau smear. And in in all the centers, especially in all the private centers and government hospitals, now the liquid-based cytology is also introduced, which gives more clarity to the cytology smears, more accuracy to the cytology reports. So as you know, the main purpose of doing a cervical smear in a female is not just for diagnosing cervical cancer. We don't want to diagnose cervical invasive cancer of the cervix. We want to detect it as early as possible. Early detection of CIN. The term has been replaced now, but you all are familiar with this term, cervical intraepithelial neoplasia, or the dysplasias of the cervical epithelium. And the categorization the system we use again is the Bethesda system. And these are the categories of cervical smear. You may get any of these reports when you see a pap smear report of your patient. You can see that negative for intraepithelial lesion or malignancy. Actually, that is the commonest report we always give in cervix. Now, our place, നമ്മുടെ സ്ഥലത്ത് നല്ലോണം കുറവാണ് ഇപ്പോൾ, as of now, cervical cancer, but we have those dysplasias, but otherwise all the patients which we used to report as inflammatory smear, ഏത് smear കണ്ടാലും അതിന്റെ റിപ്പോർട്ടിന്റെ അവസാനം pathologist എഴുതിയിട്ടുണ്ടാവും inflammatory smear. So that is now reported as negative for intraepithelial lesion or malignancy, or the NILM. Then comes the problematic reports, starting from the least malignant to the highest malignancy. So atypical squamous cells of undetermined significance, that is ascus. Low-grade squamous intraepithelial lesion is LCIL. Atypical squamous cells, but we cannot exclude an HCIL, that is high-grade cell, that is ASC-H. Then high-grade squamous intraepithelial lesion or HCIL, atypical glandular cells, AGC, squamous cell carcinoma, and adenocarcinoma. So let me just quickly go through the important entities. So NILM, I told you, it's just usually an inflammatory smear, or maybe you find a trichomonas, or maybe you find a candida or a bacterial vaginosis. Anything can come under this NILM. But if it is an atypical, if the report says that it is atypical squamous cells of undetermined significance, abbreviated as ASCUS, so that means there is mild nuclear atypia, but not that much to categorize it as a squamous intraepithelial lesion. You all must be remembering the CIN 1, 2, 3, which you all learned for your pathology as well as for your gynecology. CIN 1, 2, 3. So we used to grade as 1 when only the lower 1/3 of the squamous epithelium is involved. Grade 2 when 2/3 of the thickness of the epithelium is, and when the full thickness of the squamous epithelium is involved by dysplastic changes, we used to call it CIN 3. So now CIN 1 is LCIL, and CIN 2 and 3 are the HCIL, or high-grade squamous intraepithelial lesions. So how will you manage such patients when you see a report of ascus? So the preferred method is, of course, HPV testing, but maybe the gynecologist in the audience will be able to say later where all, like how much cases you are going to do this HPV testing, because it's not very commonly available nowadays. So HPV testing is the preferred next step. And if HPV is negative, repeat the smear in 3 years. But if HPV is also positive, in a case of ascus, we have to go for colposcopy. And if HPV testing is not available, as in many of our situations or scenarios, you have to repeat the cytology in 6 to 12 months. And if the ascus or much worse than that persists, go for a colposcopy. If after 6 to 12 months, the cervical smear has become normal, then you can start the resume the routine screening as was done before. Now about the next one, which I said, only the lower 1/3 of the epithelium shows dysplasia, that in the cytology, we get this low-grade squamous intraepithelial lesion. And it is most often due to an HPV infection, due to HPV 16 or 18 infection. Here, the management is based again on the age. So age, if less than 25 years, repeat the cytology in 1 year. So because their sexual activity has just started. So, and most of them regress within 1 year. If age is more than 25 years, again, go for HPV testing. If HPV is negative, repeat the co-test in 1 year. So co-test means pap smear plus HPV testing is called the co-test. So repeat the co-test in 1 year. If HPV is positive, then again, with LCIL, go for colposcopy. If HPV testing is unavailable, if it's just LCIL, you have to go for colposcopy. And that's about younger females. Then postmenopausal women, again, HPV testing is must, or repeat cytology in 6 months. So we have to follow them up more frequently than the younger females. Now, another higher category, that is atypical squamous cells, but cannot exclude HCIL. Here, in all these cases, we need to do a colposcopy. And if colposcopy is normal, you can still consider doing a cervical biopsy, or the patients can be kept under close follow-up. But if you find a high-grade dysplasia or an HSIL, squamous intraepithelial lesion, there are different treatment modalities, which I'm not that familiar with. The gynecologist will be knowing, like the loop electro excision procedure, excision, etc. And now the villain, the high-grade squamous intraepithelial lesion, which we previously used to call as CIN 2 or 3. There is moderate to severe dysplasia, and in these cases, there is high risk for progression to cancer. So the management is do a colposcopy as early as possible along with a biopsy, and then further manage according to the biopsy report. And for non-pregnant women, excisional procedure is often the preferred one. And pregnant women, colposcopy. But if you find something abnormal, defer the treatment for postpartum, till postpartum. So these are the different indications. Just a sum up of whatever I've mentioned. When do you need to go for an immediate colposcopy? When can you keep the patient under follow-up for 6 to 12 months? When can the patient be away for 3 years? And when can the patient be away for 5 years? So the first one, the immediate colposcopy, as I said, whenever you see an atypical squamous cell, whether it is low grade or just an atypical squamous cell or a high grade, it's always better. And especially if HPV is positive, you need to go for immediate colposcopy. But still, if you see an ascus, but HPV is not positive, then you can keep the patient under follow-up even for a period of 1 year. So this is again a tabular column showing what is the importance of all these tests and what are their outcome. So the key takeaway regarding cervical cancer screening is that ASCUS and LCIL require HPV testing to stratify the risk. ASC-H, that is atypical squamous cell, but not sure whether it is H-cell, and HCIL always require colposcopy. And definitely the age matters. But even if we are not getting a positive report, if there are persistent abnormal findings, we need to do a biopsy to rule out high-grade lesions, even if the cytology report is a low-grade malignancy or just atypical. So in conclusion, understanding the cytology reports aids in early diagnosis and management. So Bethesda system for thyroid and cervical cytology and the IAC classification systems provide structured interpretations. And all the general practitioners should know when to reassure, when to monitor, or when to refer the patient to a specialist. So these are my references: the Bethesda system for thyroid, for cervical cytology, and the Yokohama for breast. Thank you for your patient listening.
Thank you, ma'am. It was an excellent session. Abir point തോന്നുന്നു. അബീറിന്റെ കുഞ്ഞിന് ഇച്ചിരി സുഖമില്ലെന്ന് പറഞ്ഞായിരുന്നു. ബിജു സാർ ഉണ്ടോ? Anyway, ma'am has covered in detail the cytology in thyroid, breast, especially in thyroid, breast, and cervical neoplasm.
Hello? Good.
Sir, പറഞ്ഞോളൂ സാറേ. ബിജു സാർ.
Thank you. It was an ഈ ടോപ്പിക് സെലക്ട് ചെയ്ത് തന്നെ ഒരുപാട് പലപ്പോഴും ഈ റിപ്പോർട്ട് പറയുമ്പം ക്രൈറ്റീരിയയും ക്ലാസിഫിക്കേഷനും ഒക്കെ വരുമ്പോഴത്തേക്ക് ചിലപ്പം ഡൗട്ടും ക്ലാരിഫിക്കേഷനും ഉണ്ടായിരുന്നു. എനിവേ ഐ തിങ്ക് ഇറ്റ് വിൽ ബി യൂസ്ഫുൾ ഫോർ പ്രാക്ടീസ്. ഭയങ്കര നന്നായിരുന്നു. ഈ ചെറിയ ടൈമിനകത്ത് ഇത്രയും ഇൻഫർമേഷൻ പാക്ക് ചെയ്ത് തരാൻ മാത്രമേ പറ്റൂ. Thank you, ma'am, and thank you. Any questions?
Question chat box le vannittundu madam kando
chat.
Nice presentation, Kavitha, as always. I have only one question. What are the nuclear changes in papillary carcinoma?
Papillary carcinoma, nuclear changes, sir. overlapping, crowding of the nuclei, overlapping, then nuclear grooves.
What do you mean by glassy nucleus?
Glassy nucleus is like the chromatin becomes disperser, and so the nucleus will be optically clear. So that is a feature of papillary carcinoma. So any thyroid malignancy, when we see this clearing, especially in the histopathology sections, we think of papillary carcinoma. But again, the nuclear crowding, overlapping, and the grooves are very prominent in cytological smears, the grooves as well as the intranuclear inclusions. So that can be picked up well in cytology smears.
Ma'am, chat box le question under. How many slides are required in minimum for a pathologist to make confident diagnosis?
നമ്മൾ ഒരു സ്ലൈഡ് കിട്ടിയാലും എടുക്കും. ഞാൻ പറഞ്ഞല്ലോ adequacy എന്തുവാണെന്ന് പറഞ്ഞല്ലോ ഓരോന്നിലും. I've told about the adequacy. That is ഓരോന്നിനും ഓരോന്നാണ് adequacy. So thyroidന് ഒന്നാണ്, breastന് ഒന്നാണ്. But see, we take 2 smears for all cases, at least 2 slides with sufficient material. So that will give us a very confident diagnosis. But, you know, as I said, like all these features, no, cytological features must be correlated with the clinical and radiological findings also. So when you get a positive report from the clinician as well as the radiologist that this is a malignant, even few cells, even 4 or 5 cells are enough to say that we are finding malignant cells. We will report on that.
പിന്നെ മാം ഒരു ക്വസ്റ്റ്യനും കൂടെ ഉള്ളത്.
മാഡം ഈ
Arun, so we don't need many slides. I'm just reading Arun's question. How many slides? So always take at least 2 slides with good smears. Always, because we don't know, like sometimes ഒന്നും ഉണ്ടാവില്ല അതിനകത്ത് ബ്ലഡ് ഉണ്ടാവത്തുള്ളൂ. So take at least 2 slides. That is
ചില ഈ ഫൈബ്രോഡനോമസ് ഒക്കെ ആസ്പിറേറ്റ് ചെയ്യുമ്പോഴത്തേക്ക് ഭയങ്കര സ്കാൻ ചെയ്യണം. നമ്മൾ എത്ര ആസ്പിറേറ്റ് ചെയ്താലും ഒരു സെല്ലും കിട്ടില്ല ഫൈബ്രോഡനോമസേ. അപ്പൊ നമ്മൾ ചിലപ്പോൾ ഒരു സ്ലൈഡ് കഷ്ടിച്ചൊക്കെ കിട്ടും. അപ്പൊ നമ്മൾ വിചാരിക്കും ഇത് ഇതായി പോവല്ലോ, റിപ്പീറ്റ് ചെയ്യേണ്ടി വരുമല്ലോ എന്നൊക്കെ ഓർക്കും. അതാ ഞാൻ ചോദിച്ചത്. മിനിമം
അല്ല, 2 എണ്ണം വെച്ച് തന്നെ നമ്മൾ നോക്കണം, 2 എണ്ണം മെറ്റീരിയൽ. പക്ഷെ രണ്ടാമത് റിപ്പീറ്റ് ചെയ്യേണ്ട കാര്യമില്ല. കിട്ടുന്ന മെറ്റീരിയൽ തന്നെ നമുക്കിപ്പോൾ അത്യാവശ്യം മെറ്റീരിയൽ ഉണ്ടെങ്കിലേ 2 സ്ലൈഡിലോട്ടായിട്ട് നമ്മൾ പുഷ് ചെയ്യണം. എന്നിട്ട് സ്മിയർ ഉണ്ടാക്കണം. എല്ലാം കൂടെ ഒരു സ്ലൈഡിൽ ഇട്ട് കഴിഞ്ഞാൽ സ്മിയേഴ്സ് ഭയങ്കര തിക്കായി പോകും. അതാണ് ഒരു പ്രശ്നം. അപ്പൊ സോ കീപ് 2 slides side by side or 2 or 3 slides side by side വെച്ചിട്ട് സക്ഷൻ നമ്മൾ എടുക്കുമല്ലോ, നമ്മൾ യു ജസ്റ്റ് പുഷ് ദ മെറ്റീരിയൽ. സോ കുറച്ച് ആവുമ്പോൾ തന്നെ 3ലും അങ്ങ് ആക്കിയിട്ട് സ്മിയർ ചെയ്യുക, അല്ലെങ്കിൽ തിക്കായി പോകും. In case of duct ectasia in breast without wall thickening or internal echoes, how informative will be cytology of aspiration from the dilated duct contents is guided? But when you see those macrophages, no, ഇത് ഈ duct ectasia അകത്ത് എപ്പോഴും നമ്മൾ കാണുന്ന those foamy macrophages ആണ് ഒരു diagnostic feature. With that ഒരു proteinaceous material, if both are present, we can definitely give. And if you also suggest that it's going to a duct ectasia, it is a subareolar lesion, we can suggest. But otherwise, if you're not sure whether it is a duct or is it a cyst, but cyst always have more thinner fluid ആണ്, തിൻ ഫ്ലൂയിഡ് ആയിട്ടേ കാണത്തുള്ളൂ. അത് ഭയങ്കര പ്രോട്ടീനേഷ്യസ് ആയിരിക്കത്തില്ല. അപ്പൊ നമ്മൾക്ക് ഇങ്ങനെ പെയിൽ സ്റ്റെയിൻഡ് ബാക്ക്ഗ്രൗണ്ടിൽ when we see 1 or 2 macrophages and 1 or 2 ductal epithelial cells, that is more in favor of a cystic disease. But if you see abundant macrophages, thick material with other inflammatory cells like plasma cells, that's in favor of a duct ectasia.
Okay, ma'am. Thank you, ma'am. Thank you.
Okay. അപ്പൊ അത്രയേ ഉള്ളൂ ക്വസ്റ്റ്യൻസ്.
വേറെ ചോദ്യങ്ങളുണ്ടോ?
ഔട്ട് ഓഫ് ദി ടോപ്പിക് ഒരു ചോദ്യമുണ്ട്. ഈ പതോളജിയും ആക്രിക്കാരും നമ്മൾ എന്താ ബന്ധം?
പെത്തോളജിയിൽ എത്തിയില്ല, അതുകൊണ്ട് ഞങ്ങൾക്ക് അതുമായി ഒരു ബന്ധവും ഇല്ല. പെത്തോളജിയിലേക്കുള്ള വഴിയിലാണ് ആ ബന്ധമുണ്ടായത്. ഓക്കെ, ഇവിടെ 2 പെത്തോളജിസ്റ്റും കൂടെ ഉണ്ട്, റോഷിനി, മിഥില. എനിത്തിങ് ടു കമന്റ്?
Hello, Kavitha. Can you hear?
Yeah.
Kavitha, it was a very good talk. You had touched all the portions and വളരെ ടു ദ പോയിന്റ് ആയിട്ട് കാര്യങ്ങളെല്ലാം വളരെ വിശദമായിട്ട് പറഞ്ഞു. ഇറ്റ് ഇസ് സോ നൈസ് ഹിയർ ഇറ്റ് ടു യു. നന്നായിരുന്നു.
Thank
I
you.
may can I add some points from my experience now?
Sure. പിന്നെ അതല്ലേ വിളിച്ചേ.
The thing is, ഇവിടെ ചോദിച്ചിരുന്നു, സാമ്പിൾ എടുക്കുന്നതിനെ കുറിച്ച് ചോദിച്ചിരുന്നു. So we get lot of submitted slides now. Submitted samples ഒത്തിരി കിട്ടുന്നുണ്ട്. But one main പ്രശ്നം കണ്ടതെന്ന് വെച്ചാൽ, even though we see the slide, I mean we see the cells, they will be obscured by the background blood. അത് നമുക്ക് ഒത്തിരി നമ്മളിങ്ങനെ സ്ലൈഡ് ഇങ്ങനെ സെൽസ് നോക്കി വരുമ്പോൾ നിറച്ച് ക്ലസ്റ്റർ ഓഫ് സെൽസ് കാണും, പക്ഷെ കംപ്ലീറ്റ് ബ്ലഡിനകത്ത് ഇങ്ങനെ കിടക്കുമ്പോൾ ഇറ്റ് ഇസ് സോ ഡിഫിക്കൽട്ട് ടു കമന്റ് ഓൺ ദ സെൽസ്. അപ്പം വാട്ട് ഐ സജസ്റ്റ് ഇസ്, എങ്ങനെ കാണുമ്പോൾ നമ്മൾ എടുക്കുന്ന സ്പ്രെഡിങ്, ആസ് യു ഓൾറെഡി ഹാവ് സെഡ്, ഇറ്റ് ഇസ് നോട്ട് ദ നമ്പർ ഓഫ് സ്ലൈഡ്സ് വിച്ച് ഇസ് ഇമ്പോർട്ടൻറ്റ്, റാദർ കിട്ടുന്ന മെറ്റീരിയൽ ഹാസ് ടു ബി സ്പ്രെഡ് വെൽ സോ ദാറ്റ് വി ക്യാൻ കമന്റ് ഓൺ ദ സ്ലൈഡ്സ്. ഇത് ബ്ലഡിനകത്ത് ഇരിക്കുകയാണെങ്കിൽ ഇറ്റ് ഇസ് സോ ഡിഫിക്കൽട്ട് ടു കമന്റ്. നമുക്ക് ATP എന്നൊക്കെ പറയാനേ പറ്റത്തുള്ളൂ, കൂടുതൽ ഡീറ്റെയിൽസ് കൊടുക്കാനായിട്ട് പറ്റാതെ വരുന്നുണ്ട്. അപ്പം അത് എടുക്കുന്നവരൊന്നും കൂടെ ഒന്ന് നോക്കിയാൽ ഇറ്റ് വുഡ് ഹാവ് ബീൻ ബെറ്റർ. ഓക്കെ, ദാറ്റ്സ് ഇറ്റ്.
Thank you. മിഥില, എന്തേലും ഉണ്ടോ?
ഉണ്ട്. അതായത് മാം പ്രസന്റേഷൻ വെരി നൈസ്. അതായത് മോസ്റ്റ് കോമൺ തിങ്സ് തന്നെയാണ് മാഡം കവർ ചെയ്തത്. പിന്നെ ഞാനൊരു പ്രൈവറ്റ് ലാബിൽ വർക്ക് ചെയ്തപ്പോൾ എനിക്ക് കിട്ടിയ അനുഭവങ്ങൾ എന്ന് പറയുന്നത്, നമുക്ക് മെയിൻ ആയിട്ടും പിന്നെ ഒന്ന് കുറച്ച് സീനിയർ പെത്തോളജിസ്റ്റ് ചിലപ്പം അപ്ഡേറ്റഡ് ആവാതെ ഓൾഡ് കാറ്റഗറി തന്നെ കൊടുക്കും, അതൊന്ന്. പിന്നെ രണ്ടാമത്തേതിന് ഈ ജനറൽ പ്രാക്ടീഷണേഴ്സ് ആർ യൂസ് ടു ദി ഓൾഡ് സിസ്റ്റം. അപ്പൊ അവർക്ക് പുതിയ സിസ്റ്റം ഈ ഇപ്പൊ നമ്മൾ IAC കൊടുക്കുമ്പോഴൊക്കെ അവർ നമ്മൾ എന്തോ തെറ്റ് ചെയ്യുന്ന പോലെ ചിലപ്പം വിളിച്ചു പറയും, വാട്ട് ഹാവ് യു ഗിവൺ, ഐ ഡോണ്ട് അണ്ടർസ്റ്റാൻഡ്. അപ്പം അങ്ങനെയുള്ളത് ആ ഒരു സിനാരിയോയിൽ ഈ ക്ലാസ് ഭയങ്കര റെലവെന്റ് ആണ്. ശരിക്കും കുറച്ചുകൂടി ആൾക്കാർക്ക് ഇത് റീച്ച് ചെയ്തിരുന്നെങ്കിൽ നന്നായിരുന്നു. നമുക്ക് തന്നെ തോന്നും ചിലപ്പോൾ ചില സർജൻസിനോട് പോയി പറയണം, ഇങ്ങനെയാണ് ഇപ്പൊ നമ്മൾ റിപ്പോർട്ട് ചെയ്യേണ്ടത്. അതാകുമ്പോ നിങ്ങൾക്കുള്ള കൺഫ്യൂഷൻ അവോയ്ഡ് ചെയ്യാം, നമ്മുടെ ഉള്ള കൺഫ്യൂഷൻ അവോയ്ഡ് ചെയ്യാം. അങ്ങനെ പിന്നെ വരുന്നത് ആൾക്കാർക്ക് ലീഷൻ ഹെട്രോജിനിറ്റിയെ കുറിച്ച് ഒരു ഐഡിയ ഇല്ല മാഡം. അതായത് ഒരു FNAC എടുത്തു, അത് നമുക്ക് അതിന്റെ മറ്റൊരു ഭാഗത്ത് വേറെ ഫൈൻഡിങ് ഉണ്ടാവാം എന്നുള്ള ഒരു ഐഡിയ ഒരു കോമൺലി ഇല്ല. നമ്മൾ FNAC എടുത്തു, അതിൽ ഇങ്ങനെയാണല്ലോ കണ്ടത്, അപ്പം ഇതിനകത്ത് മറ്റേത് പറഞ്ഞിരിക്കുന്നല്ലോ, അങ്ങനെ ഒരു നമുക്ക് കംപ്ലൈന്റ്സ് വരാറുണ്ട്. പിന്നെ ഉള്ളതെന്ന് പറയുന്നത് ഹാർഡ് ലീഷൻസ്. ഇപ്പം ഒരു സാറ് കമന്റ് ചെയ്തില്ലേ, അപ്പൊ അത് നമുക്ക് FNAC-യിൽ അവര് ഒരു സെല്ല് എങ്കിലും കിട്ടിയില്ലേ അങ്ങനെ ചോദിക്കുന്നവരുണ്ട്. അപ്പൊ ആ ഒരു സെല്ല് കൊണ്ട് നമുക്ക് ഒന്നും പറയാൻ പറ്റത്തില്ല, അതല്ല ലീഷന്റെ റെപ്രസെന്റേറ്റീവ് അല്ല എന്നുള്ളതും. പിന്നെ ഹാർഡ് ലീഷൻസ് നീഡിൽ കയറില്ല, നമുക്ക് ട്രൂ കട്ടോ ഒരു എന്തെങ്കിലും ഒരു ബയോപ്സി തന്നെ, ഒരു സ്മോൾ ബയോപ്സി തന്നെ വേണ്ടി വരും എന്നുള്ള ഒരു പോയിന്റും ചിലർക്ക് അത് നമുക്ക് കൺവേ ചെയ്യണമെന്ന് തോന്നിയിട്ടുണ്ട്. പിന്നെ വെരി സ്മോൾ ആൻഡ് സൂപ്പർഫിഷ്യൽ സ്കിൻ ലീഷൻസ് FNAC-ക്ക് വരുമ്പോൾ ഉള്ള ബുദ്ധിമുട്ടുകളുണ്ട്. അപ്പൊ നീഡിൽ ത്രൂ ആൻഡ് ത്രൂ അങ്ങ് പോകും. അപ്പൊ അങ്ങനെയുള്ള ഒരു സബ് സെന്റിമീറ്ററിക്കും മില്ലിമീറ്റർ സൈസും ഒക്കെ ഉള്ളത് നമ്മളൊരു ബ്ലൈൻഡ് FNAC-ക്കൊക്കെ വിടുമ്പോൾ അത് വെച്ചാൽ FNAC-യുടെ ലിമിറ്റേഷൻസ് അറിയാതെ അതിൽ നിന്ന് നമ്മൾ ഓവർ എക്സ്പെക്ടേഷൻസ് ഭയങ്കരമായിട്ട് ജനറൽ പ്രാക്ടീഷണേഴ്സിന് ഉണ്ട് ചിലർക്ക്. അപ്പൊ അതും കൂടി എന്തായാലും നമ്മൾ ഒരു വെൽ അവെയർ ആക്കിയാൽ നമുക്ക് FNAC ഒരു ഒപ്റ്റിമൽ രീതിക്ക് യൂസ് ചെയ്യാൻ പറ്റും എന്ന് തോന്നിയിട്ടുണ്ട്. ഓക്കെ മാം,
താങ്ക് യു സോ മച്ച് മിഥില. ഡോക്ടർ ഷഫി ചോദിച്ചിട്ടുണ്ടായിരുന്നു നമ്മുടെ ഇത് എന്താന്നല്ലേ, ഫിക്സേറ്റീവ്. നമ്മൾ ഐസോപ്രോപ്പൈൽ ആൽക്കഹോൾ ആണ് യൂസ് ചെയ്യുന്നത് ഫിക്സേറ്റീവ് ആയിട്ട്. വേറെ എന്താ ചോദിച്ചേ?
പിന്നെ കവിത, can you please tell about the fixative also? Because dry smears വരുന്നതും അതിനെ കുറിച്ചൊന്ന് how ഫാസ്റ്റ് ആയിട്ട് നമ്മൾ അത് ഫിക്സേറ്റീവിൽ ഇടുന്ന കാര്യം.
അത് ഞാൻ അരുണിന്റെ ക്വസ്റ്റ്യന്റെ കൂടെ അതുകൂടി പറയാൻ, ബിക്കോസ് ഞാൻ നമ്മുടെ IMA കഴക്കൂട്ടത്തിൽ തന്നെ ഇതിനു മുമ്പ് സൈറ്റോളജി ടെക്നിക്സിനെ പറ്റി ഒരു ബിജു ലാസ്റ്റ് ഇയർ ഒരു ടോക്ക് തന്നിരുന്നു, ലൈക്ക് ഹൗ ടു ടേക്ക് FNAC എന്ന് പറഞ്ഞിട്ടേ. അപ്പൊ നമ്മൾ എന്ന് വെച്ചാല് ഈ ഞാൻ നേരത്തെ പറഞ്ഞ പോലെ നമ്മളെല്ലാം സെറ്റൊക്കെ റെഡി ആക്കി വെച്ചിട്ട് വേണം എപ്പോഴും ആസ്പിറേറ്റ് ചെയ്യാൻ, എസ്പെഷ്യലി ഇത് റേഡിയോളജിസ്റ്റിനും. ഈ അല്ലാതെ നമ്മൾ ഈ സാധനം എടുത്തു കഴിഞ്ഞിട്ട് പിന്നെ കോപ്ലിൻസ് ജാർ തുറക്കാനും സ്ലൈഡ് നിരത്താനും ഒക്കെ പോയി കഴിഞ്ഞാൽ അത് തന്നെ മതി. ഇതാ നീഡിലിന്റെ മറ്റേ സിറിഞ്ചിന്റെ ഹബിലും നീഡിലിന്റെ ഹബിലും സിറിഞ്ചിന്റെ അകത്തിരുന്ന് തന്നെ ഡ്രൈ ആയി പോകും. പിന്നെ നമ്മൾ സ്പ്രെഡ് ചെയ്ത് കഴിഞ്ഞാൽ ഉടനെ തന്നെ കോപ്ലിൻ സ്റ്റാറിൽ, അതുകൊണ്ടാണ് ഞാൻ പറഞ്ഞത് നമ്മൾ ഈ ആസ്പിറേറ്റ് ചെയ്യാൻ തുടങ്ങുന്നതിന് മുമ്പ് തന്നെ വി ഹാവ് ടു കീപ് ദറ്റ് കോപ്ലിൻ സ്റ്റാർ ഓപ്പൺ. എന്നിട്ട് അതിങ്ങനെ മലർത്തി വെച്ചാൽ മതി, അല്ലെങ്കിൽ അത് ഇവാപറേറ്റ് ചെയ്യുമല്ലോ. അപ്പൊ മലർത്തി വെക്കുക, എന്നിട്ട് ഫാൻ ഓഫ് ചെയ്യുക. റൂമിൽ ഫാൻ ഓഫ് ചെയ്യുന്നത് വളരെ ഇമ്പോർട്ടന്റ് ഒരു കാര്യമാണ്. എന്നിട്ട് നമുക്ക് ഏറ്റവും ഹാൻഡി ആയിട്ടുള്ള, പെട്ടെന്ന് നമുക്ക് തിരിഞ്ഞു നിന്ന് ആ സ്മിയർ പിന്നെ ഇത് ചെയ്യാനുള്ള, പുഷ് ചെയ്യാനുള്ള ഒരു കൈ നമ്മൾ പറയത്തില്ലേ, ആ ഒരു സൗകര്യത്തിന് തന്നെ അത് വെക്കുക. എത്രയും പെട്ടെന്ന് ഡ്രോപ്പ് ഇടുക, സ്മിയർ ചെയ്യുക. ഇങ്ങനെ ഫാസ്റ്റ് ആയിട്ട് ചെയ്യണം. എത്ര ഫാസ്റ്റ് ആയിട്ട് ചെയ്യുന്നു അത്രയും നല്ല ക്വാളിറ്റി ആയിരിക്കും സ്മിയർ കിട്ടുന്നത്. ഇപ്പം റോഷിനി പറഞ്ഞ ആ ബ്ലഡിലെ സബ്മിറ്റഡ് സ്ലൈഡ്സിൽ ബ്ലഡ് കൂടുതൽ ഉണ്ടെന്ന് പറയുന്നത് പോലെ തന്നെയാണ് ഈ ഡ്രൈയിങ്. ചിലപ്പോൾ നല്ല ചങ്കായിട്ട് ടിഷ്യൂ കിടക്കും, പക്ഷേ നമുക്ക് റിപ്പോർട്ട് ചെയ്യാൻ പറ്റത്തില്ല, കാരണം അത് ഫുള്ളൊരു ഡ്രൈഡ് അപ്പ് ആയി പോയി. അപ്പൊ ശരിക്കും പറഞ്ഞാല് നല്ല രീതിയിൽ ചെയ്താൽ സബ്മിറ്റഡ് വെച്ചും നമുക്ക് റിപ്പോർട്ട് ചെയ്യാൻ പറ്റുന്നതാണ്. ആൻഡ് മിഥില പറഞ്ഞത് വളരെ പ്രാക്ടിക്കൽ പോയിന്റ്സ് ആണ്. ഈ പറഞ്ഞ കണക്ക് നമ്മളെല്ലാവരും ടെർഷ്യറി കെയർ സെന്ററിൽ ഇരുന്ന് സൈറ്റോളജി റിപ്പോർട്ട് ചെയ്യുന്നതും, I have also worked, like soon after my PG, I worked for 1 year in DDRC. So I know what all happened there. അതെനിക്കറിയാം. അപ്പൊ പക്ഷേ ഞാൻ ഈ നമ്മളെല്ലാം പറഞ്ഞ ഐഡിയൽ കാര്യങ്ങളാണ്. when we present only the ideal things, the ideal scenarios, the systematic റിപ്പോർട്ടിങ് ഇത്ര സെല്ല് വേണം, അത്ര സെല്ല് വേണം എന്നൊക്കെ. പക്ഷേ ചില എല്ലാം കൂടി നമ്മൾ, ഇറ്റ്സ് ഓൾ എ ജിഗ്സോ പസിൽ. നോ, ദ ഡയഗ്നോസിസ് ഇസ് ഓൾവേസ് എ ജിഗ്സോ പസിൽ. സോ വെൻ വി ഹാവ് എവറിഥിങ് and when we see 2 or 3 cells, we may be able to make a diagnosis. So thank you so much, CGP, Biju, Abir, Vinita, for giving us this opportunity. I must say us, because pathologists are always kept behind the curtain. But it's so important that once upon a time, I mean, once in a while, pathologists and clinicians should talk. That's very important. Thank you.
Not once in a while, ma'am, frequently. The clinicians and pathologists should talk to each other, keep in contact. Then only a right diagnosis, we reach a right diagnosis. Anyway, Biju sir undo ado sir illengi njan vote of thanks parayam on behalf of Abir.
വിനീത പറഞ്ഞു, ഞാൻ ഓഡിയോ ചിലപ്പോൾ ബ്രേക്ക് ആയി പോകും. വിനീത പറഞ്ഞു ഔട്ട് ഓഫ് താങ്ക്സ്.
Okay. Thank you, Kavitha ma'am. It was an excellent session. You covered in detail all the things, especially the thyroid, breast, and cervical neoplasm, which was the need of the hour, and along with visual illustrations also. And the way you simplified this complex clinical cytological findings with correlating with clinical practice was truly remarkable. And on behalf of IMA Kalkuttam, I sincerely thank you for sharing your expertise and for making this session informative and engaging. And special thanks to Roshni ma'am and Dr. Mithila also for adding important points. And we greatly appreciate your time and effort. I also extend my heartfelt gratitude to the CGP team for arranging this session with an expert of the field. And also I thank all the attendees for your active participation. So thank you on behalf of IMA Kalkuttam. So can I wind up the session?
Yeah.
Thank you and good night.
Yes. Thank you. ഞാനാണല്ലേ.
ആ മാഡം ആണ് എന്റെ ചെന്നെ, ഞാൻ നോക്കിയിട്ട് ചെയ്യാൻ പറ്റുന്നില്ല.
കൊടുക്കാം. Okay, good night everyone.
Good night.
Yes.